presenting our knowledge translation on a study that we found called Dapagliflozin once daily and Exenatide once weekly dual therapy. So it's a randomized 24-week placebo-controlled phase 2 study, and it uses this intervention and studies the effect that it has on body weight and the effect that it has on the people developing diabetes in the future. It's a study that was actually published in 2016, and it's Swedish, and it's actually, oddly enough, founded by AstraZeneca.
Why is it odd? It's odd because AstraZeneca is the company that produces Dapagliflozin or Farxiga, so it's something to keep in mind as we continue on.
So the population that they actually studied was obese adults without diabetes in the age range of 18 to 70 years old. And there was a BMI of 30 to 45 that you needed to be in order to be considered.
So if you're 18 years old, there's a very good chance that you'll have an easier time losing weight than somebody who's 62. And they probably also have higher rates of insulin resistance after a long period of time as opposed to if you were 22 or younger.
Yeah. So the intervention that they actually used was oral dapagliflozin 10 milligrams once daily, along with a subcutaneous injection of Exenatide 2 milligrams every week. And then they did a placebo for the other half of the group. So there were 50 people altogether that were studied, and they were divided 25 and 25 into intervention and control.
Yeah, this was a really strong study in terms of their study design. So they had a double-blind trial where the personnel and the patients were blinded for the full 24 weeks. And the allocation concealment happened through containers. It was a one-to-one computer-generated allocation. So we like the strength of the study design because it really minimizes the risk of selection bias.
And before looking at the study, I think it's important to kind of make a connection between the study itself and the general population. And as we know, in Canada, obesity is a huge problem. 1 in 3 Canadians are obese and require medical attention to kind of help control their weight. And currently in Canada, pharmacotherapy is warranted if you have a BMI of more than 30 or a BMI of more than 27 with cardiovascular risk factors, which is good because that's the population that our study contains, so that makes it a little more generalizable. And currently in Canada, there's only 3 drugs that are actually indicated for weight loss, and they're Xenical, Saxenda, and Contrave. So it wouldn't hurt to kind of explore more options and see what is the most beneficial in this type of population.
The worst thing though is that all of these drugs are pretty expensive, and they're usually not covered because weight loss isn't seen as a sort of life-saving intervention.
Right.
They didn't really talk about cost in the study at all, so it's hard to say if this new combination would actually be any better. There's also the fact that they didn't include people with diabetes, so we can't really then extrapolate these results into patients that we see on a daily basis.
Yeah, they're excluding a huge part of the general population that we'd be looking at for sure. Yeah.
Just looking at the results kind of objectively, there was a difference of body weight of 4.13 kilograms in the intervention group. There was a decrease of systolic blood pressure of 4.13 milligrams of mercury. And there was a significant decrease in the sugar results in the intervention group, and they significantly decreased after using the intervention. So it definitely decreased their risk of getting diabetes in the future.
Mm-hmm. So one thing that we like is that the primary outcome, which is body weight reduction, is important to patients. It's something they see, it's something they can measure themselves. It's important to them in this disease. But with the outcome, there's a 20% dropout rate in the placebo group. So we're thinking about attrition bias here, and that because it's body weight reduction, it's going to favor the intervention in this case.
A couple things that were left out of the study as well, like smoking status, alcohol intake, and exercise and diet were kind of put on the back burner of the study. They kind of encouraged it but didn't enforce it. But smoking can kind of increase the amount of calories you burn. Alcohol introduces more calories into your body. So those are important factors that they didn't even really touch on at all that would have been important and helpful in judging the benefits of the treatment group. It's important to note that pharmacotherapy should not be monotherapy. It should be intertwined with exercise and diet as well in order to have sustained weight loss.
And so we really like the study design, but we're wondering how generalizable is it to the population?
We should make sure that we're controlling the age range. We should be controlling what comorbidities they have, and we don't know what ethnicity these people are, aside from the fact that they're Swedish.
Yeah.
The fact that the study was only 6 months long, so they didn't really follow up in terms of how the patients were doing after that period of time. I'm just interested to see if those are long-lasting results or just something that came after the 6-month treatment.
Yeah. So it is promising. They did lose weight in the intervention group. I mean, it was pretty much the same amount as the difference that was initially there from the allocation, because the intervention group was a little bit heavier than the control group. But really, this is just promising for future studies because it does show a little bit more optimism towards pharmacotherapy for weight loss. But like Jesse said, it's never going to replace diet and exercise. And the fact that socioeconomic status is a huge factor when it comes to weight loss. Like, can you afford these drugs that are probably a fortune? You know, so it's good. The science is pretty good, but the actual real world consequence isn't there yet.
Thanks for listening, everyone.
All right, take care.
Thanks.
Bye.